Good morning. Thank you so much to Kathy Shalou and to Louise Kohlmeyer. The ALERT program and the Boston Lymphatic Center are truly world-class centers of excellence for lymphedema. And I'm so privileged that our paths continue to cross. And I look forward to future collaborations. And I'm very thankful to LE&RN and the Boston Lymphatic Center for sponsoring this symposium. I'm here to speak to you about prospective surveillance, early detection and diagnosis of breast cancer-related lymphedema. And I do give the caveat that my research program is on breast cancer-related lymphedema. I'm a strong proponent that we have a lot more work to do for patients who suffer from lymphedema of other etiologies, but my research is focused on breast cancer-related lymphedema. These are my disclosures. Just a quick poll. I don't think we can poll the people at home, unfortunately, but how many people here work in a facility which offers some type of lymphedema screening? I see hands, which is great, because a few years ago, we would not have seen hands. So I think this is a step ahead. How many of you have thought about how to implement a screening program at your facility or would like to implement some kind of screening program at your facility? I see more hands. Good. So let me tell you a little bit about our screening program. Same as Louise said, I am very lucky to be able to have the privilege to both see patients and also run a research program at MGH, and they feed each other. I can take my research to my bedside clinical care and inform our patients, and I can come up with my clinical questions because I know what the patients are looking for, and through our discussions and our long rapport, these questions come out. So at MGH, our screening program started in 2005. Since that time, we've screened about 7,500 women for breast cancer-related lymphedema. This is a schema of how we see patients through the program. So we see patients firstly in their preoperative visit. This is a very stressful day when the patients are at MGH to meet with their oncologists and develop their surgical and treatment plan of care. So that day, we just get that ever so important preoperative baseline measurement, which is, I will say, the hardest part of a screening program, to get that preoperative measurement. But we don't do anything else that day. It's a heavy day for the patients. We then see patients in the postoperative visit. And at that time, we know what the patient's risk factors are for lymphedema. And I'm going to go into that in more detail today. We do use outcome measures to look for symptoms that we know are indicative of developing breast cancer-related lymphedema. We refer patients for clinical exam as needed, and we really start to educate the patients. We want to empower them, as Louise said, to give some control over this chronic disease. We follow them every 3 to 6 months. For as long as they'll let us. We would love to follow them for 5 years. I think right now our median follow-up is just under 3 years, but as long as they will come back for measurements, we will always measure them and see them. We start at preoperative baseline, and I will reiterate this throughout my presentation, but we start at preoperative baseline because a lot of women have a baseline arm asymmetry before their surgery. And if we don't know that, and we are diagnosing lymphedema based on right-left arm volume differences alone, without thinking about symptoms and clinical exam and all those other things, again, Louise spoke to so nicely, then we are misdiagnosing a number of patients. So we looked at data from 1,028 women who we'd screened in our program. And what we found is that 28.3% of those women had a baseline arm asymmetry of 5% or more. So if you're just diagnosing postoperatively, you would have diagnosed 28.3% of these women as having lymphedema, and they don't before their surgery. And 2.9% of these women had a preoperative asymmetry of 10% or more. So we really need to be armed with that information. And what I'd like to do today is I'm going to give you lots of evidence and lots of support for screening. And I hope that you can go away feeling like, how did I practice without a screening program? And I hope that you feel empowered to take some of this information back to the teams you work with, to the multidisciplinary teams you work with, and develop some kind of support in your facility for a screening program. So We also looked at whether or not, because it's so hard to get this baseline measurement, could we take a measurement right after surgery or 3 months after surgery? And could that be, per se, a pseudo baseline measurement that we could use to monitor over time? And the answer is no. Lack of a true baseline really results in significant misdiagnosis. And this is across tools. This is any volumetric tool. And there have also been studies using BIS that have found that patients have, and a small number of patients with BIS have an abnormal reading at baseline. So we really do need that baseline measurement. And we found here that when we looked at measurements from these 1,028 women, we would have under or over diagnosed lymphedema up to 55% of the time without the preoperative baseline measurement. For our clinical program, we use a perometer or limb volumeter to measure the volume of each arm. You could do the same thing measuring with tape measures and converting to volume. You could use a 3D camera, which is an evolving method of measuring as well. We developed this relative volume change formula and we validated this formula. The reference is there. And we measure each arm at each visit and we put the median arm measurements into this formula. So A in this formula is the affected side, U is the unaffected side. Time 1 is preoperative baseline, and time 2 is the postoperative follow-up measurement. So we have an Excel spreadsheet, and we pop the measurements in as we're doing it, and it calculates this for us. It's also in our EMR template, so it makes it a little easier. Obviously, it would be hard to do this at the point of care without some kind of spreadsheet. And this is, I think we spoke nicely to this as well, the lymphedema continuum of care. I always start with screening, because we should be doing this preoperatively for patients, and that's when it starts. But we can prevent lymphedema. We can try to prevent lymphedema either through surgical means or conservative means, like using a compression sleeve after surgery. There was just a nice study published. Actually, one of the first author just joined the alert team in Australia, I think a couple of months ago now. And that showed that we can potentially prevent lymphedema progression or lymphedema by using a compression sleeve postoperatively. We can do conservative intervention, either early intervention that we will speak to more in a few minutes, or traditional CDT. And finally, for those who are still having issues post-conservative intervention, we can send them through to surgical reconstruction, which I've done all too often over to the BI here, and they've graciously seen our patients. No matter where patients are on this continuum of care, it comes back to screening. And I think Louise captured this well too, that if we're trying to prevent lymphedema, we have to monitor them for progression. We're not curing it through prevention, right? We are still going to see some patients, even though we're trying to prevent it, we're going to see some patients end up with lymphedema, and we need to catch that early and treat that early. And the same with conservative intervention. We can't just put a sleeve on a patient and say, off you go. We need to educate, exercise, sleeve, and then send them back to the screening program, and we watch for volume changes. And so often through our screening program, we can see small volume increases that the patient hasn't even felt yet. And we know the arm is creeping up, have them come back in. We might change what we're doing. We might add night compression. Maybe they need a newer garment, a different kind of garment. And then we try to get that back down again, put them back into screening. We've already talked about this, and I don't feel like I need to tell anyone in this room about the impact on quality of life of lymphedema. I put a few references here. I really think this is underestimated amongst a lot of people who practice in the oncology world. And there are more than one study, Louise spoke to one, where lymphedema is really the primary fear-inducing factor after breast cancer diagnosis, secondary to recurrence. And there's a number of studies that say that. So the quality of life impact is huge for these patients. And where early intervention and prospective surveillance come in is that the relationship between the severity of lymphedema and the impact on quality of life is not linear. And you can probably think of patients you've had too. I've had patients who have 7% edema or 12% edema, and a horrible impact on their quality of life. And I have a woman now who has 40% lymphedema and tells me she's not bothered at all by it. It really just depends. So if we can try to catch it early and try to minimize the effects on quality of life. The patient, this should almost say the patient in the middle, in the green circle here, but these are patient-centered goals of screening. Our goal is to improve quality of life, to minimize treatment burden, both in cost and time. And this is both for the patient and the system. I agree, we can really minimize the burden by giving less visits, less intensive therapy, because that's not what the patient needs when we're truly screening them, for the most part. We can decrease hospital admissions because hopefully these patients are not having later stage chronic lymphedema and are developing recurrent cellulitis when we see those hospital admissions. We can prevent progression, so we keep them in earlier stages or maybe never develop lymphedema at all. And I think most importantly, giving the patient some control over what can be a lifelong disease and hopefully never experiencing the later stages and feeling like she has the autonomy to know what to do if she feels her arm is changing. Evidence for screening really started in the early 2000s, and Nicole Stout's study is probably one of the better cited early supports for screening. She screened 196 women after breast cancer diagnosis with spirometry. And when their volume went up 3% from preoperative baseline, she put a compression sleeve on them for 1 month. And then she followed them over several months. The volume of their arm dropped, and they maintained that drop in volume over a few months. And that was really one of the first studies that pointed to the fact that if we measure them preoperatively and follow them over time, that we're going to be able to prevent progression. And the same year, our team presented in the ASTRO meeting, the radiation oncology meeting, data from 2,179 patients, trying to look at what the threshold cutoff should be for surveillance and treatment. And in that presentation, we found that we recommended 5% for very close surveillance and potentially early intervention, or 10% for a traditional clinical lymphedema that required immediate treatment. Since that time, several studies have shown that screening is feasible, it's sustainable. And these are larger hospital systems, but I'm seeing more and more smaller hospital systems. I'm getting a lot of calls saying, how can I do this in my hospital? What can we do on a smaller scale? And there's a lot we can do. But here are 4 studies that have published the successful feasibility of screening programs. The one on the top left is our program, and that's from 2016. Screening patients has a tremendous impact on decreasing cost. And I've given you a few references here, but the last reference I think is striking. Lymphedema-related US hospitalizations from 2012 to 2017 resulted in more than $1 billion in reimbursed costs. So if we can be decreasing visits, certainly decreasing cellulitis risk and hospitalizations, this has a large impact on everyone, most importantly the patient, but also the system. I have to highlight this paper because this is Dr. Kohlmeier's team's paper, and it's a really lovely paper published in 2019. They screened 753 women with bioimpedance, and they compared a traditional model of care where patients did not get early screening to a surveillance-based model of care where they did get early screening. And they found that those who were in the traditional model of care, they got lymphedema care later. They had more clinical lymphedema, and they had more later stage lymphedema. So this is a nice study that brought us not only to the success and feasibility of screening, but the impact on early intervention and patient outcomes. There is a lot of evidence for early intervention. Here are a number of studies and their main findings in very much a nutshell since 2002. The intervention has not always been compression in these studies. In some studies, it's range of motion, it's exercise, but in all of these studies, they found a benefit of early intervention. We only have a few truly randomized controlled trials that are small. So I think there's more work to be done to figure out who benefits most from early intervention so we can risk stratify that as well. So the data really suggests that early intervention prevents progression to lymphedema. I would argue that you cannot intervene early unless you're screening. You simply won't find the early swelling unless you're really screening. But all subclinical lymphedema does not progress to lymphedema. So we've done a lot of work trying to figure out who is it who progresses and who may benefit most from early intervention. The practice is moving that way. And I would argue that early intervention is not a one-time need. It's not a blip in the radar and we put a sleeve on and then we send the patient off and they're fine for the rest of their life. It's really a continuum of care that's longitudinal, and we're developing a good rapport with this patient and she's coming back in as needed. And we're screening her. So we wanted to look at this area of early intervention. And this, I'm just going to present data from a small retrospective study of our work. And we wanted to assess the effectiveness of early intervention and prospective screening for low volume or subclinical swelling in preventing lymphedema progression in a cohort of women treated for breast cancer and screened at MGH. So we included patients with unilateral breast surgery in our screening program with a baseline measurement with a first episode of low volume swelling. So we define that as a relative volume change of 5 to 10% from preoperative baseline. And they all had perimetry measurements within a month of starting physical therapy or occupational therapy and within 2 weeks of the end of treatment. When we applied that criteria, we had 30 participants. Keep in mind, this was at a time when this wasn't the norm to treat these patients. So these were 30 patients who we did treat early at a time when traditionally we weren't doing that yet. And this is just a schema of how they would go through the early intervention. So we were screening them. They'd be referred for RVC of 5 to 10%. We would do early intervention. If the RVC dropped, we would just return them back into screening and watch them carefully. If they had ongoing issues, we would see them again and they'd have another further episode of care. If the RVC was more than 10 with early intervention, generally we would go right to CDT. And if we couldn't get the RVC down, we would refer to lymphatic surgery. This was a high-risk group because at the time we weren't traditionally seeing these patients. The ones who were getting referred were high risk. So 2/3 of them had a BMI more than 25, 70% had node dissection, and 77% had received regional lymph node radiation. There were 64 episodes of care amongst these 30 patients. One of them actually had 7 episodes of care. And the median follow-up was nice and long in this study. It was 42.6 months from the first RVC of 5 to 10%. Because this was a retrospective study, we did not have a treatment protocol, so it was very individualized. So the patients could have received a number of different treatments, but as we would hope and expect, all of them, well, 62 of 64 received education. I would hope that the other 2 were documentation oversights, because I would hope that we're educating all of our patients. And most patients received some kind of compression, and all patients did receive some kind of exercise. So in the first episode of care, the median RVC was 7.45% at the beginning. That dropped to 5.26%. And there was only one patient who had an RVC over 10 at the end of the episode of care. And interestingly, this patient's arm exploded during her care. She went from about 8% to 23% in 10 days. And I immediately got on the email to Dr. Singhal and said, can you please see this patient? She's exploding through I started CDT, her arm just kept going up. And he ended up doing lymphatic surgery on her quite quickly. And she's doing incredibly well. So just being able to put a patient like that through the early intervention, the screening, and having access to a lymphatic surgery program, really, that was a good outcome for her. So there were 64 episodes of care, as I mentioned. And although this was subclinical lymphedema, there was swelling documented on clinical exam in 56 of the episodes of care. It might have been subtle and it might have been focal, but these patients had some amount of swelling, even at a very low RVC. When we look at how long it took patients to progress from that low volume swelling, for those who did, there were 4 patients who progressed to lymphedema at the end of an episode of care. And when we look at the timeline of that, the time from initial elevation to RVC 5 to 10% to breast cancer-related lymphedema of more than 10%, elongated. We delayed the onset of lymphedema. And we can tell that because patients who had node dissection, their median time to progression was about 12.9 months, or about a year after they first measured for having that increased swelling. It took them about a year to progress. In our previous data in patients who didn't receive early intervention, that was 6 to 8 months. So it looks like that time doubled. And the same could be said for sentinel node biopsy. And when we looked at time from surgery to RVC more than 10%, that was even more striking. Those who had node dissection, it was a median of 30 months from time of surgery to RVC more than 10. Our historical data was 6 to 12 months for that same population. So it felt like we're delaying this, but again, this is a really small study. So we just need to keep that in mind. Overall, throughout the follow-up of the study, half of the patients exceeded an RVC of 10% at some point. That sounds terrible when you say that, right? We've been screening these patients, they're referred for early intervention, and half of them got an RVC over 10%. So let's look at why that is. And let's look at their final outcomes. So 12 of those 15 had undergone node dissection and regional nodal radiation. And most of those 12 had a BMI more than 25 at time of breast cancer diagnosis. This was a high-risk group who was progressing. And I would argue even when we do early intervention, we may not always prevent getting over 10, but we can certainly control this disease. So let's look at outcomes for those 15 people who progressed to RVC more than 10. There were 15 of them, and there were only 3 of them with RVC more than 10 at final follow-up. One of them was really stable post-conservative management. She had no symptoms. We had weaned compression totally, and her RVC was 10.5. So I'm going to call that a win. The second patient, her condition was stable. This is the patient whose arm exploded during lymphatic surgery, and her arm came down beautifully from, I think, 45% at its worst. She's now at 13% in compression, no symptoms, good quality of life. The third patient, and again, life happens. This patient is caring for her elderly parent with Alzheimer's and also for a child with significant disabilities. And she cannot have any more surgery or any treatment. It's just not possible in her life. So she has some compression, but her RVC is about 27%, and she's been lost to follow-up. There were 12 patients with an RVC less than 10% at last follow-up. So they measured over 10% at some point, technically lymphedema, together with symptoms and clinical exam, but 10 of them resolved with conservative management and are stable at less than 10. And 2 received lymphatic surgery and are stable at less than 10 and doing very well. One could argue, again, that lymphatic surgery, maybe that's not the best outcome for patients who have early intervention, but at the end of the day, their RVCs are good, their quality of life is good, and they're in control of their disease now. So in conclusion, we prevented progression to lymphedema in 29 of 30 patients on the first episode. So if we published that paper, and many of the early intervention papers are published this way, we gave a sleeve, we followed them for 6 months, 90% of them are fine. I think we need to follow them longer, and we need to look at the fact that early intervention is just part of this prospective surveillance model of care. 90% of participants had RVC less than 10 at last follow-up. And those who progress seem to be this high-risk group. So this is a group we need to really watch very closely. We may delay and lessen the severity of lymphedema over time with early intervention. And again, it's really a first step. It's part of the continuum of care. We did not have a treatment protocol for this study, so I'm guessing that different studies that have different protocols are going to have different findings. And I don't think we've found the perfect early intervention protocol just yet. All of this data has really led to guidelines and recommendations for screening popping up, that we should be doing screening for these patients. And I would argue it's standard of care. And I agree with Louise that every patient who's diagnosed with breast cancer and is at risk of lymphedema should have access to a screening program. Otherwise, we are really doing a disservice to these patients. And when patients come in from outside and didn't have access, in Louise's words, they feel ripped off because they really wish they would have had that baseline measurement and been followed over time, so we would have caught it earlier. So anything we can do to help support everyone in this room in trying to give you the evidence and the support for screening, anything we can do, we would be happy to in terms of collaboration. But in terms of guidelines, of course, I put the LE&RN guidelines up first. This is really a nice document, 10 things to know about preventing chronic cancer-related lymphedema of the arms and legs. They recommend routine testing when the patients see the doctor or therapist. And that's a good point. Our screening visits are when the patient's coming in to see her oncologist. We don't have them come in just for isolated screening visits. Many live pretty far away. So they come in and see their oncologist and we screen them while they're there. And it also recommends a pre-cancer treatment baseline. The NCCN guidelines recommend a pre-treatment baseline and regular screening using symptoms, clinical exam, and objective measures. The NAPBC guidelines recommend surveillance for lymphedema. The American Society of Breast Surgeons baseline and follow-up measurements of both arms. The NLN guidelines, which are a little older now, I believe they're in the process of rewriting these as we speak, but pre-treatment measurements on both arms and post-treatment measurements on both arms at each visit. The APTA in 2017 came out with a clinical practice guideline. I think there's a lot of PTs and CLTs in the audience, so I'm sure many of you have seen this. They do recommend a preoperative measurement and using either BIS or volume to diagnose lymphedema, and also using self-reported symptoms or patient-reported outcome measures. I applaud the authors for putting together a clinical practice guideline like this. This is a mammoth task. If you've written a systematic review or a clinical practice guideline, this is a mammoth task. And I think there are a lot of really good things about this CPG. However, we did write a letter to editor and comment on this CPG together with Dr. Singh's group, because there's no clear recommendation in this guideline about prospective surveillance and baseline measurements being imperative. They do make a recommendation that it's okay to use volume measurements in absence of baseline, which we know causes significant misdiagnosis. And there's no recommendation for this multidisciplinary approach, which is really the cornerstone, the foundation to this treatment of lymphedema. So I would say there's a lot of great things about that guideline, but just look at that together with some of the other guidelines that are published as well. I looked for an OT guideline because I know there's a lot of OTs in the audience as well. I couldn't find a lymphedema specific guideline, but there is a nice practice guideline on for adults with chronic conditions, recommending a preventative approach. And I would put this into the preventative approach category. Risk factors. So we know that screening is cost effective. We know it's feasible. We know that early intervention seems to be successful to prevent progression. How do we know who to screen for lymphedema? These are the very well-known and well-documented and well-supported risk factors for breast cancer-related lymphedema right now. And we'll just go through the research behind those and explain them a little bit more. So node dissection and regional lymph node radiation first. We published data from 1,815 participants in our screening program with a median follow-up of 52 months. And we stratified by nodal surgery and regional lymph node radiation. And we calculated the 5-year lymphedema rates on the right here. And I have red boxes around sentinel lymph node biopsy only and node dissection only. So you can see that patients who undergo node dissection are at 3 times the lymphedema risk of patients who only undergo sentinel node biopsy. Those who undergo sentinel node biopsy are not at 0 risk. I do want to say that. I will educate patients that although your risk is low, it could happen. And I've seen a handful of people over the years who've only had a sentinel node biopsy and have a low BMI who do develop lymphedema. It doesn't happen often, and I'm sure there's probably something anatomical with those patients. I would love to image them with ICG. And that's probably a really good study, Louise. But we do need to keep in mind that they're not 0 risk. And when we added regional lymph node radiation, that increased the risk a little bit, but the primary driver The primary driver of lymphedema risk surgically is the node dissection, not the regional nodal radiation. So as soon as I see node dissection in the history, I know this patient's in our high risk category. And then we think about all the other risk factors and whether or not those things are adding to risk for the particular patient. And this is, I think, why, and I find this schema really helpful to look at. So when a sentinel lymph node biopsy is being done, the area of the tumor in the breast is injected with blue dye, and that drains to the sentinel nodes, or the first nodes to accept that dye. And those nodes are removed, and pathology is done on those nodes to check for cancer. In node dissection on the right, the level 1 and 2 lymph nodes are removed by the surgeon. All of that tissue around those lymph nodes are removed to the medial border of pec minor. So all of the pink, red nodes and purple nodes would be removed, and the fat pad and all the tissue around it are removed. It's a much more intensive and invasive surgery than the sentinel node biopsy. And I think that's why the superficial lymphatics and lymphatics altogether, plus the removal of lymph nodes, is such an insult to this area and increases the risk dramatically. I do think we're going to be living in an era where we don't have node dissection anymore. And there's a study being done and a study that's come out looking at whether or not we can eliminate node dissection and just do node biopsy for the majority of breast cancer. So I think we're going to see that number go down. I believe at MGH right now, only about 20 or 25% of women undergo node dissection. It's mostly node biopsy, which has been good for the lymphedema risk. And for the patient, just in terms of, we all see the patients after node dissection, they're so uncomfortable, the axilla is tight. It's much, much better surgery to have to go through. BMI more than 30 at cancer diagnosis, not post-treatment, and weight fluctuations. So we published a study on 787 women from our screening program looking at the impact of BMI and weight fluctuations on lymphedema. And what we found is that patients with preoperative BMI more than 30 or weight fluctuations more than 10 pounds during and after treatment are at higher risk for developing lymphedema. So you can see the figure on the left. The top line is those with a BMI over 30. That might be a little bit small. And that was statistically significant. We also published data looking at whether or not weight loss, because we educate patients about maintaining a healthy weight after treatment. And we also know how difficult that is for these patients on endocrine treatments to decrease their weight, especially for those who may have gained 20 or 30 pounds during chemotherapy. And we looked at whether weight loss, in fact, decreases risk of lymphedema, and it does not after treatment. And we were not the only ones to publish that data. Katie Schmitz's group, she was responsible for the PAL trial, the exercise trial. This was also a randomized controlled trial by her group, and she too found that weight loss was not protective. So we may recommend weight loss or maintenance for other reasons, but we should not be educating that it will decrease lymphedema risk. Low volume or early swelling. This is data from 1,790 patients. We wanted to see in our screening program who develops this 5 to 10%, who develops this low volume swelling, how many people develop that, and of them, who goes on to develop lymphedema. And this was before we did early intervention. So this is an absence of early intervention. And what we found is that those who had node dissection, 39.7% of them developed this low volume swelling at some point post-surgery. So that's a lot of people. Almost half of people had this blip in swelling, which is concerning for them because they know they're high risk. And of them, almost 40% went on to develop lymphedema. So that's really high as well. So that's a number I'll give to patients when they come in for early intervention. We know your RVC is elevated. You're at about a 40% risk of progression. And that's in absence of an elevated BMI or cording or any of the other risk factors. So as soon as we say that, the patient will say, what can I do? I'm happy to wear the sleeve. Let's do early intervention. And it's a really motivating number because we can hopefully prevent this. Those who underwent node biopsy, 24.4% of them developed low volume swelling, and only 11% of them went on to develop lymphedema in absence of treatment. So almost 90% never developed lymphedema, never had treatment. So I will tell those patients, in absence of any other risk factors like elevated BMI, and we'll talk about one of Dr. Kohlmeyer's studies, we have some time to watch and wait if they really don't want to have a sleeve on. But many will say, put it on. I'm happy to wear the sleeve. Let's try to prevent. And we'll do that together. Black race and Hispanic ethnicity has come out in the literature in the last few years as being risk factors for breast cancer-related lymphedema. There are 2 studies that have found that. And in this particular study, it's a huge study, almost 3,000 patients, long follow-up of 4 years. Black women had a 2-fold increased lymphedema risk compared with white women. African genetic ancestry was also associated with higher risk, and non-obese Hispanic and African American women had a higher risk than white women, which was not fully explained by things like node dissection and BMI. It really was associated with their ethnicity. The second study out of Memorial in New York City, 276 patients with a nice follow-up, also found that Black race and Hispanic ethnicity were independently associated with increased risk. So we need to be thinking about this as we're seeing patients who fall into those categories. They're at much higher risk. Role of breast reconstruction. We published this study in 2016, and we looked at 616 patients with a median follow-up of 22 months. And we found that those who did not undergo reconstruction at time of mastectomy were at a higher risk of lymphedema. We held on publishing this data because that was concerning to us, and we certainly don't want patients making surgical decisions at time of breast cancer diagnosis based on lymphedema risk associated with reconstruction. So we delved pretty deeply into this, but we did find that those who underwent immediate implant reconstruction had a significantly lower risk of lymphedema than those who did not undergo reconstruction. We did not find the same for autologous reconstruction like flaps. The incidence of lymphedema was not lower in that population compared to no reconstruction. We're not the only paper. We actually held back publishing this until there were 3 other papers that published the same thing. So there are now 5 papers that say the same thing from 5 different groups. We even updated our cohort in 2018 to almost 1,000 patients. We reanalyzed statistically and found the same thing. There are the references there. There are 3 hypotheses for this, because one wonders, how can that be? One is that we spare the skin with skin-sparing mastectomy, so we preserve the lymphatic channels. And that may, in fact, allow for lymphatic drainage of the breast and the axilla. And because with no reconstruction, we have more resection, so more impact on the lymphatic channels. With tissue expansion and capsular contracture around an implant, we get some tissue ischemia, expression of VEGF, angiogenesis, and lymphangiogenesis. This is another potential way that we see this lower risk. And with no reconstruction, we've seen patients like this. With no reconstruction, more adhesions, more fibrosis. I would argue in patients with a really low BMI, I see this as a bigger issue, and I do a lot of manual therapy over the trunk and chest wall for those patients after they've had radiation, because we get a lot of adhesions. And finally, cording. We wrote this paper a couple of years ago on 1,181 patients, and 31.7% reported cording at some point after surgery. So this was self-report. We did not confirm with a clinical exam, just as a caveat. And patients who reported cording had over double the odds of developing lymphedema as those who didn't report cording. So I arm patients with this if they're already at high risk of lymphedema and they're telling me they had cording or I see cording. I'm telling them that that's going to probably add to their lymphedema risk, and we're watching them carefully. And we know from a couple of studies, for many years, we didn't know what cording was, and now we know that cording is probably due to lymphatic origin. So it may make some sense that these patients have some occlusion and inflammation around the lymphatic vessels down the arm, and therefore they may be at higher risk. I incorporate MLD for these patients. I incorporate kinesiotape to drain the arm with these patients with cording because I know it's a risk factor. It's also uncomfortable for many. Other risk factors that are a little more controversial include taxane-based chemotherapy. Several studies have found this to be a risk factor. We have not found it to be a risk factor. We found it to cause transient edema, but not long-term lymphedema. We also started to see at MGH, one of our oncologists reached out to us and said that patients who are undergoing targeted therapies, like abemaciclib, the PI3K inhibitors, mTOR, CDK4/6 inhibitors, they were starting to see swelling in the arms and legs of these patients. And they referred a few patients through to me whose arm just exploded 3 to 4 weeks after starting these treatments. So we're studying this right now, and we don't really know if there's an effect, but it's something that we're looking at, and maybe something to look at in your patients in terms of what treatments they're taking on, because if it is associated, I've found that swelling to be really tenacious and refractory to my care. Lymphatic anatomy, I think the BI is doing a beautiful job of this, and Alert is doing a beautiful job of this, and I think I'll leave that with them this weekend. And genetic predisposition, I think we will hear more about that as well. So we know what the risk factors are, and we know who we should be screening, how long should we screen for, and how should we use those risk factors. This is a paper that was just published by the Alert group, and this past month, actually, and we wrote an accompanying editorial, and they did a beautiful job. I'm sorry if this is too small, but a beautiful job of risk stratifying based on the risk factors they found into low, intermediate, and high risk for lymphedema, and then translated that into a model of care for screening in terms of how frequently these patients should be seen. So you can see for all levels of risk, they recommend a preoperative baseline measurement and a postoperative 3-month follow-up. But then for the lower risk group, they recommend 6 monthly visits versus for the higher risk group, they recommend 3 monthly visits for years 1 to 3. So in facilities where all of our facilities are resource limited, I think it's good to be able to give a framework to risk stratification for the screening program and be able to give patients at low risk a little bit more room while still watching them, not saying they're at no risk, but to make sure we're watching those high-risk groups really carefully. Nigel Bundred's group, I'm sorry, this is a bit blurry, but Nigel Bundred's group out of the UK also studied this and put together a model for risk stratification for screening using low, moderate, and high risk. So when are patients at most risk for lymphedema? And this is why we try to screen our patients as long as we can. We looked at data from just over 2,000 women in our screening program to look at the natural history of lymphedema. When are you most at risk? So for the whole cohort, which is the red line, the risk was highest between 12 and 30 months postoperatively. For those with node dissection, so the higher risk group, it was earlier. It was 6 to 12 months, really increasing, and 6 to 24 months in all for the node dissection group. Whereas for the lower risk group with sentinel node biopsy, it was further out, 36 to 48 months. And for that lower risk group, I'll use that in my education and say, you are at lower risk, but the people in your category tend to get lymphedema later. And I see that clinically too. So don't let your guard down. I don't want you to be fearful, but I do want you to be looking, 3, 4, 5 years later. And if you feel anything different, I want you to call. And they do, and we do catch it. So the non-negotiables, baseline preoperative measurement, monitoring for 3 to 5 years, individualized education about risk factors, signs and symptoms, self-screening, and a screening protocol, and that low risk is not equal to no risk. At minimal, I think for the low risk group, we should be doing a baseline measurement, educating them, having them be vigilant, and self-refer when they need us. And best practice is really some kind of longitudinal surveillance, maybe as Dr. Kohlmeier's group said, at a lower frequency, but still some kind of longitudinal surveillance. I would be remiss if I didn't mention breast and trunk edema. This is an area, as Louise talked about, that we have been working on, and we've just published a paper on, or we're publishing a paper on. The incidence is high in one prospective study, up to 63% post-breast conserving treatment. We see a lot of signs and symptoms in these patients. They will tend to have high levels of pain. I was just speaking with someone this morning, and she was saying she had a patient who was a teacher, and she had 5-year-old students who loved to jump up in her arms and give her a hug. So it's very hard when you have a swollen and very sore, Leslie, yes, swollen and very sore breast. So this is something that impacts quality of life. We're very interested in understanding who's at most risk and in trying to develop effective treatments for this. So there's lots of support for screening, right? It's evidence-based. We know who's at risk and when. We know we can identify it if we measure for it. It allows for early intervention. It's feasible. It's cost-effective. Patients should have access if they're at risk. It's a guideline, and it should be standard of care. And this is what I would love to bring back to your facilities and try to convince and put together that multidisciplinary team to be able to screen these patients. So components of a screening program. This is how we think of breast cancer-related lymphedema diagnosis. We put all of this data together. So patient-reported outcome measures. We know that arm swelling or a change in arm size, when patients tell us their arm is swollen or they have a change in arm size or arm heaviness, that's indicative of developing lymphedema. And that, I should have put the references on here, but that's 3 different studies that have found that. So look for outcome measures that look for those 3 symptoms. We use the Lymphedema Symptoms Experience Index, which we really like because not only does it ask about those symptoms, it asks about the distress caused by those 3 symptoms. And there are many other validated tools. I would say just find one that fits into your clinic workflow and gathers the data you wish to gather. Patient education and risk stratification. We've already talked a little bit about risk stratification. I would point you to the Boyages et al. Study, which is out of the ALERT group that was just published for risk stratification. Understanding that axillary surgery is the primary driver of risk, but that other factors add risk as well, and we've talked about those. Patient education, individual risk factors. The patient needs to understand exactly what has given her risk of lymphedema and what that anticipated level of risk is. The frequency, so we'll tell patients every time you're here visiting your oncologist, we're going to grab you, we're going to ask you to have a measurement, we're going to give you the tablet to fill out the outcome measures and what those components of our screening program are. We will tell the patient in writing and verbally what the symptoms of lymphedema are and the signs of lymphedema, and we'll give her contact information. They have the information for the lymphedema screening program, so they will call, I felt something different. Our research coordinators will send me an email. They'll get a referral from the MD, and I'll go ahead and see the patient. Patient vigilance and self-screening. Our screening program would fail if patients did not know what to do between our screening visits. If we're really only seeing them every 3 to 6 months, and some patients every 6 months, they need to know when to call us. So a lot of it is what we'd like them to do between screening visits and when to call. Objective measures. Louise touched on this quite a bit, and she's right. You can do a bad measurement with any one of these tools. It really requires a strict measurement protocol. We have all of these tools at MGH, and we use them both for research, and the clinical decision-making tool for us is the perometer. And girth measures converted to volume, 3D camera, and perometer are all measures of volume. So you can use the RVC equation for those measures using a spreadsheet, for instance. And bioimpedance spectroscopy is not a measure of volume. It's a different construct. We're looking at extracellular fluid using that tool. So I just put together a quick table about each of the measurements, and we are looking at different constructs. So we are not going to diagnose the same women with lymphedema if I'm measuring them on a perometer and a BIS, because we're measuring different constructs. That's why the symptoms and the clinical exam piece are so important in addition to your measurement. All of them require a strict protocol for measurement, or the measurements won't be accurate. Preoperative baseline is required. There are good thresholds for lymphedema in the literature that are well established and can be used for any of those tools. The tape measure is low cost, and it needs a place in lymphedema screening. I think most of the world is going to have to continue to use a tape measure for quite some time. So just being sure to validate measurements, convert them to volume, use the RVC. It is possible to do a screening program if you're validating each other's measurements and training. There are space requirements for all of them, I suppose, except the tape measure. You could have 5 in your handbag, apparently. And time to perform measurement with technology is really low. With a tape measure, it's a little higher, but it's still a very feasible portable tool. What not to do with objective measurement. So you need the baseline. So the 2 centimeter difference, the 200 milliliter difference, the percent difference without the baseline is just not accurate. And I would say if you're using those measurements, rely more heavily on your clinical exam and the symptoms than you do on that measurement, because it's really not very accurate. And it's not based on objective measurements alone. Clinical exam. This is a nice tool. This is the CLUE tool developed by Katie Schmitz's group. And I have this in my EMR, in our EMR template. And you score different anatomical regions for obscuration of anatomical architecture, deviation from contour, pitting, and tissue texture. And it's a really nice way to measure change over time in clinical exam. So starting a screening program. You need a multidisciplinary team. Absolutely. It really takes a village to get this into place. Consider the facility support, and I would argue push the evidence. There's so much evidence for screening if you can bring that back to your group, and I'm happy to also help with that. Cost, it is much lower to screen these patients than not to screen them. Consider the type of equipment. What works for us is not going to work in your clinic probably. Consider who is doing the measurements and what staff training needs are required. The companies who sell these technologies are absolutely brilliant at helping to train staff to use them well. They want you to use it well. They want you to get good data, and they want the patients to be appropriately diagnosed. So they will come and work with you, any of them. Clinic workflow, what works for your clinic? How do you get that baseline measurement? It took us a long time to figure that out because we don't want to steal a patient from the surgeon's waiting room or from the surgeon's exam room. And our research coordinators basically throw themselves across the door waiting for some of them. You saw this Monday, Louise, waiting for some of these patients so they can get that measurement. Having a good trigger for referrals. So our research coordinators take the measurements. They understand when a patient measures X, they're going to send me an email, they're going to ask for a referral and make sure that patient gets care. And if I get the email, then I know what the measurement is. I know how the patient felt. They might say the patient's really anxious. Could you call her today? And that allows me to reach out right away and get the patient in even sooner if I can. CLT availability and practice challenges. That's been challenging. And unfortunately, with the way resources are, we have tremendous patient volume and only so many hours in the day. But unfortunately, I've spoken to so many patients the last couple of years who've had CDT once a week. And that's not CDT. And that's unfortunate because they've been going for months. And when you give them good, high quality CDT and they see their arm come down, that's where we want to be. And I would argue if you can't do that, as Louise said, use the network to try to find someone who can. Or what we've started to do, pointing at one of my therapists and my other therapist, what we've started to do is see patients for consult, get them into a good reduction wrap, teach them self-MLD, and see some reduction before we can get them to CDT, which is several days a week, not 1 day a week or 2 days a week. And finally, we are having successful collaborations, getting screening programs together. We just worked with Boston Medical Center. They serve a population that is 40% Black, and they're at very high risk of late-stage cancer and therefore very high risk of lymphedema. And they're screening all of their patients now. They're using a different device, very different workflow, different spreadsheets, but we help them get that into place by visiting them and trying to put in place what worked for them. And it's going beautifully. So we can hope for more collaborations like this. We too love collaborating. So I bring you back to this, that it's really a continuum of care for these patients, and it comes back to screening. If we want to intervene early, and we do, then we need to be screening. These are the things to consider. I've already gone over many of them when you're thinking about developing a screening program, how to develop a program that really fits into your clinic. And I would argue you need the surgeon on board because they're the only ones sometimes seeing the patient preoperatively. It really takes a village. I am so lucky that I have an amazing one at MGH. This is everyone historically on our screening program, our lymphedema research program. I'd like to say thank you to all of them. And we have 3 of our therapists here today, Nora, Sophia, and Janet, and they are shouldering tremendous patient volume with grace and amazing skill. And for that, I'm thankful, because it also allows me to get to my research work as well. So thank you to my team. You can reach us here. I have a QR code for our website that has all of our publications. Our email address is there, and the social media platform, previously known as Twitter, page is here as well. So we're happy for people to reach out. If we can be part of helping someone answer questions or develop a screening program, that would be a privilege, because that is our goal, is that everyone has access for lymphedema screening who is at risk. Thank you for your time.